Hey everybody, this nice little intimate group, we're gonna get a couple people I think that'll float in. I just wanted to take this second to say like this is something very special to us, and I think that the opportunity to start having these conversations at national conferences is long overdue. And so I feel like I'm amongst friends, family members, or whatnot. I'm going to let my colleagues get a chance to introduce themselves. I'm Italo. The name of our talk today is Health Equity Rounds. It's a primer and a facilitator workshop. This is going to be your introduction to what health equity rounds are, the various ways that it's been called, what we'll achieve with it, and give you the insight on how to run it at your own respective shops. I'm going to go ahead and pass the mic so that my colleagues can introduce themselves.
Hello, everybody. I'm William Dixon. I am at Stanford, so we're all at Stanford. I'm the clerkship director for the advanced clerkship, so the students who are going into emergency medicine. Been at Stanford for a couple years, did a master's in education at Penn, and then a fellowship at Stanford as well. And so we've been, of the many places that we've been doing these health equity rounds, over the last 2 years we've been doing it with our students that rotate through in the emergency department.
And my name is Moises Gallegos. I'm one of the other clerkship directors. I handle more of the core required clerkship. We actually became a required clerkship just recently, so all of our Stanford students have to rotate through with us. And I was a Stanford medical student myself, and I've seen where a lot of the conversations have gone while I was at Stanford over the years and transitioning. I actually left for residency, but part of the reason I decided to try and make my way back as a faculty was that these types of conversations are always pushing the envelope at Stanford and within not just our group in EM, but across the school. And so knowing that this was some of the stuff I wanted to get involved in long term, I knew that Stanford would be a place to foster the asking of the social EM type questions, especially for our trainees and learners. And so although I don't have as much experience, say, with each of the individual products that have been produced, it's been great to sort of learn from each of these two gentlemen. I'm also currently working on my Master's of Education, trying to get the learning theory behind a lot of these concepts.
Cool. Italo, I am also with these gentlemen, assistant professor in EM. I trained at I would say, our fellowship in social EM at Stanford. The background and impetus to do all of this work, though, comes from a couple of individuals I have to acknowledge. Alden Landry, who is the outgoing president of ADIEM. He gave a talk here this morning. He's largely taken me under his wing. We've known each other for some years, and so I acknowledge him as someone who kind of like set the wheels in motion for me to do this. And we're giving acknowledgments again to our department chair, Andra Blumkons, who again empowers us to do this work. And it's really awesome to have support from within to be able to do things that are considered non-traditional but benefit everyone. So these are a list of our disclosures. None of them are currently active. The other thing is I want to establish a zone of safety. So when we have conversations about things that are considered controversial, it's important to start off by like setting the tone and saying like this is a safe space. Everybody comes with a different perspective and biases are present. In fact, I acknowledge that as a presenter, I operate with a male, black, heteronormative bias. I tend to focus on anti-black sentiment, and sometimes that bias is what I say. This is okay. This is a safe space. The goal is to acknowledge these biases up front. The second thing is that some of the conversation is going to be triggering, right? We have this conversation, and there are elements of it that you might personally remember or recall, or you may have experienced or seen or advocated for somebody. So acknowledging that up front, that this has the potential to trigger individuals, is important. So those traumas we've experienced, we're going to unpack a little bit today. But hopefully, regardless of our frames of identity, the skills that we'll learn today will help us navigate these conversations with a little bit more ease and hopefully turn us into ambassadors for this type of work. So I just want everybody to think about why we're here today. Like what your personal goals are, what your personal hope was when you saw this come across your screen on the SAEM app. Anybody want to share with me kind of like what they thought when they saw the name or the title? It's going to be very conversation-based, y'all. We might be here in jackets, but I promise you it's just going to be real down-to-earth conversation. What's up?
So I'm Nicole Donato, one of the assistant program directors at the University of Florida at Gainesville.
Great to meet you.
As part of my role, I design a lot of nationally where it's not a difficult conversation at that point. So kind of like wanting to tailor it back and start from scratch and figure out how best I can approach the topic.
Thank you. First off, I've been there. I felt that before. I've been in rooms where these conversations, someone starts talking about racism, and all of a sudden, like, my spider senses start tingling. I know what you're talking about, and then wanting to do it in such a sensitive way that everybody feels like they're at the table. So I know what you mean. Okay. Anyone else want to share what made them seek this out or saw it and said, "Hey, this is kind of interesting"? How you doing?
Hi, so my name's Amika. I'm a first-year resident at Aventura.
Cool.
So I don't know if it's like a Florida thing, but I also so I'm actually helping spearhead our DI curriculum that we're gonna get going with.
Wow.
One of our APs is one of our faculty, and it was just spurred out of like me saying the same thing, like co-residents, attendings, faculty, saying things or having explicitly showing their implicit biases.
Right.
To the point that they're explicit biases, and we all come from different backgrounds, and we have a very diverse group of residents and faculty. But for some reason, we don't translate that into having proper conversations about these things in a safe space.
Sure.
And we have a very diverse population of patients. From like that, in my opinion, like a DI curriculum that is suitable at UF isn't suitable at my residency program. So that's my goal of being here, to try to like learn more so that I can help create that curriculum, because it is important for my colleagues to be able to understand and self-reflect and see how that affects their patients.
Absolutely.
I was just going to say that, so myself, acknowledging my own bias, so first gen, Mexican American, being able to speak Spanish to some of my patients, whereas maybe some of our providers don't have an interest in these topics, I still get uncomfortable, right? I still struggle with how much is too much, how much is critical versus what can be sort of glanced over, right? Because you also don't want to have this imbalance of we're doing too much, or we're trying to sort of, for lack of a better expression, beat a dead horse. And so it's about trying to find a balance, and those conversations are developing continuously, right? As more understanding of the topics come out, as more structured educational frameworks come out. So it's about acknowledging these difficulties and these challenges too, and highlighting the desire, though, that you guys are saying, right? There's this desire to want to represent that at our programs, and being willing to embrace that discomfort. Right?
Oh, yeah. I'm absolutely, no, please feel free to share. Yeah, no, go ahead. We can go back.
Hi, my name's Angie. I'm an alcoholic.
Join the club.
Right.
I'm the social emergency medicine fellow at University of Iowa, and I took this because apparently in 3 months, or July 1st, I'll be the director for the Department of DEI, and maybe I should know something about it, besides I just know how to be a black woman in medicine in the U.S.
We'll give you some support there, but early congratulations, and it's something that we should walk into with a good feeling, and I want you to be like, know that you can do that.
So in the morning, I'm like, I got support.
There you go.
Okay.
Well, we'll empower you a little bit more today. So we're going to take a second. I wanted to look at this statement of purpose. This is generally what I share to tell people or introduce them to what Health Equity Rounds is. So Health Equity Rounds creates space for discussion on critical topics, critical social topics like racism, xenophobia, gender inequity, and ableism. The series allows all classifications of learners to identify, process, and deconstruct issues of equity and justice using a didactic approach. And through case-based learning, residents can explore root causes of inequity and how these influence clinical outcomes. We have a couple of primary and secondary objectives, not of this lecture, but of what Health Equity Rounds accomplishes. Feel free to go ahead.
Yeah, and so part of what we are going to talk about a little bit later, it's with any curriculum, it's about being purposeful. Being purposeful and acknowledging what the goals, the objectives are, being purposeful with acknowledging what it's not going to be and what it's going to be difficult to be. And so one of the things we want to get across more clearly is that there will be some very, say, easier to hit tasks, and then some others that we hope develop as a result of the debrief and maybe some more introspection and personal review. So in terms of primary learning objectives for a session like the health equity rounds. In the domains of knowledge, skills, and attitude, it's going to be a lot easier to, say, hit on the knowledge, potentially influence a little bit of attitude. And in this case, as a facilitator workshop, we're also going to hopefully try and develop some skills. But within that, it's very common to review drivers of health within the social realm, right? And so it's a good avenue and a good venue to try and review those social determinants and social drivers of health, and that's very sort of built into the structure of the rounds themselves. Being clear about definitions and sort of formulating what the health disparities that we're discussing are. Differentiating the health inequalities from inequities and defining equity on a term that we can all be very comfortable utilizing, and then introducing the concepts of social justice and how that factors into like a medical practice and what we're doing as clinicians. And so these primary goals, I think, are a little bit easier because they're sort of in the line with defining terms, making sure that we're all on the same page, using the same language, so that then when the conversations develop, we all are on a better understanding of those back and forths. So a little bit easier to hit some of those primary learning objectives.
And then our secondary goals, which kind of stem a little bit more, develop a little bit more through the conversations that we've had. The plan is to increase resident or medical student or learner, whoever this health equity rounds is targeting, increase awareness and understanding of a few of these really important topics, including implicit and explicit bias, the existence of microaggressions and what to do about them, upstander actions, which we'll go over, but I'm sure some of you have heard of what an upstander is. And then, if you can't tell, I'm as white as it gets. And so this has been, I actually have not had a lot of like imposter syndrome when it comes to medicine. Like I feel very comfortable being a physician. I did through all of residency and med school, etc. I don't have a family in medicine, but just for whatever reason I didn't. But this is something that I have a good amount of imposter syndrome for because this is something that's really new to me and it's been a strength that something that I've had to develop. And Italo and I did a lot of the sessions together, and then I did one by myself with 10 medical students, and I was like, well, what do I know about this? But it actually went pretty well. And so, allyship or anti-racism is something that I'm, obviously actively working on from a ally standpoint, both in these sessions, but then also now when I start to see things in the emergency department, then I can a little bit more effectively target. So those are some of the things that kind of come out of our discussions.
So this is a workshop that's going to be delivered in two parts, okay? The first part where we'll go through the background and the anatomy of what doing one of these is like, a health equity rounds experience. You'll spend some time actually going through the case and seeing like how you actually navigate it. And then the second part is more of facilitator training. That's where we'll start to get into the nuts and bolts of like, all right, how do you write your case? How do you plan for delivering this? How do you collect feedback? How do you, like the actual substance of demonstrating a health equity round series? So without further ado, I'd love to just start launching into a little bit of this talk. Everyone needs to understand the basic language when we talk health equity. This is your crash course to understanding not just the terms, but how they're surgically used. I've got a couple of definitions here. Social and structural drivers of health is replacing social determinants of health. So if you're still using social determinants, change that to drivers, right? The main idea here is that these are non-medical drivers of health outcomes. So things like access, employment, insurance, you guys know a lot of these already, but they now have a different umbrella term. Differentiating this from health disparities is important because for a lot of people, they think this is all one blurred line, and it's really an arc. It's like a spectrum. So health disparities result from a lot of these different social determinants as well as other things. These are discrepancies in health outcomes between groups. So when you're comparing a group versus another group, if there is a disparity or a disadvantage visualized, that's what we would call a health disparity. Health equity, this is the expectation that every person, regardless of whatever their group classification or identity is, has the access or the ability to achieve optimal health outcomes. Oh, I can go back for you. Now this is, usually I put like a little picture somewhere, be like, this is the one you want to get. What's up?
Why did you go from determinants to drivers?
So the idea was that these are forces that contribute to something. They don't necessarily determine these outputs. So they, as contributing factors, they're driving these outcomes because of their existence. Determinants felt a little absolute, and it doesn't necessarily incorporate structural elements. So when they changed it to, it was first of all social determinants of health, then it was structural determinants of health outcomes, and then they just kind of tethered these back, volleyed these back and forth. So this is the most accurate vernacular being used. The most current, excuse me, not accurate, the most current, the latest iteration. If in the past couple of years you've been paying attention to the media, these two words, equality and equity, have been kind of thrown around interchangeably. And I'd like to just make these separate ideas. I'll use this analogy of a racetrack to understand the difference. So equality represents when all stakeholders get the same resources no matter what their circumstances are. Whereas equity is really taking into account those circumstances and using that to inform the resource allocation so that stakeholders have the opportunity to get the same outcomes. If we're looking at two racetracks, right? So think Summer Olympics, if you're looking at that track and the numbers are lined straight across, that represents equality. All the numbers start at the same place, all the runners start at the same place. But if you think about the lanes themselves, the innermost lane runs a shorter distance than the outermost lane. And so to create equity, they stagger the lanes, right? So this is a visual way that I explain to learners about the difference between equality and equity. And I think it helps from an analogy standpoint. Most people have seen this complicated graphic before. I just like to show it because I think that it itemizes every single one of the determinants, or excuse me, drivers. This is a slide that I used from a determinants lecture. Sorry about that. Things that we don't often think about falling into the landscape of social drivers are present. Things like debt, right? Like we don't consciously think about how that can affect someone's ability to be healthy. We already think about food or access to meals, but considering where you live can also change those things. So I encourage you to look at these types of lists to get a broader view of what drives our health outcomes that have nothing to do with medical or with your health, your medical history at all. And when I share this with learners, I typically want them to see this center column. The center column shows you a breakdown in percentage of what contributes to health factors, eventually leading to health outcome differences. Notice that social and economic things are 40%. So a substantial amount of social and economic factors substantially can change what your length of life and quality of life are. That's why we have to focus on this as well.
Italo, can I comment on that
Sure.
real quick? So the last couple of years, I've had the opportunity to give an undergraduate course at Stanford as well. And it's related in terms, but the topic is ethnicity in medicine and how ethnicity specifically as one of the categorizations of what might influence your health is. And even at the undergrad levels, freshman and sophomore, they have some concept of how this breaks down, right? I usually put a slide up and I ask them to match up or line up, which one do you think actually contributes the most, which one contributes less. And the reason I bring that up is that I think one of the issues in these types of topics and workshops is sometimes again, how much is too much? What should we be talking at what level? Our youth are already primed for this, right? They live this, they see this, it's all over every social media aspect. They're watching our societal happenings unfold, right? So they're already primed to understand that there's way more than just these clear health, physical, mental health outcomes. And so it's just been really interesting for me to see it on the undergrad level and then sort of how that transitions into the med student level and then our trainees as well and residents. It's just sort of it's building up and it's happening early.
So we've all seen patients that look like this. We've seen the dialysis patient who comes in, missed dialysis multiple times. We've all looked at a patient's face when the medical information glossed right over them because it wasn't delivered in a language that they speak, right? It wasn't delivered in their native language. The looks on our patients' faces who have to travel far and wide to reach the services, who might come in incarcerated or who have nowhere else to go. All of these things represent health outcomes or changes in health outcomes. And so I use visuals when I give this talk so that people can put faces and images and bring things together and not just see the words on the text, the text on the slide. But there are other features that we don't often share, like how employment, specifically if you work in a migrant community or if you have part-time employment, how that can change your ability to get an optimal health outcome or have a PCP, or even you might show up in the emergency department a lot more because of this. Folks who live in communities where receiving care, is very limited, but they've created community within that. And so they serve as each other's wellness centers, and how that can be limiting. And even communities that are over-policed. If you walk through the streets of New Orleans, I guarantee you'll see a difference in how the police presence is in their ability to achieve optimal health care. So we have to be conscious of this when we have this conversation. When we talk about race, most folks don't have an operative definition. There's one that I believe is a little bit too scientific. This definition, I think, helps us to understand very point blank period that this is a social construct, right? It's a way of categorizing people based upon a system of oppression. And if we think about that and teach that, it reprograms the learner to say, all right, this is not necessarily a way I classify, a population for a medical study or for some type of scientific research. It's actually built around a socio-political element. And then there's racism. So this is the result of this particular social construct. So when I show these two slides back to back and I have that conversation, I say, all right, I want you to understand that this is built out of a socio-political construct, but then a belief system grew from that, right? And then I go through usually an entire arc of conversation around the history of race, and then where we end up now with the Human Genome Project that shows that there are more similarities among other quote-unquote races than just within one single identified social group. It's usually powerful at that point. But this slide, I think, encompasses it the best. It shows us how health outcomes are affected by racism, how racism modifies health outcomes. At the individual level, gives rise to collective. So multiple people operating with individual racism creates collective racism. Then systemic and structural features that are embedded compound that. And then finally, you get the systemic element of it where it's chronic. It's gone overlooked for so long that now morbidity and mortality rates all differ based upon these same lines. Now at every single point, honestly, 1, 2, 3, and 4, you can have social determinants of health or social drivers of health amplify the effect or compound that effect. Over the past couple of years, these conversations have become more prevalent, right? We've been sitting in meetings, we've heard these from different training sessions, and it creates this illusion that we're getting closer to equity. But until we're able to have these dialogues with surgical precision and the language for our learners, specifically in medicine, then we really haven't struck the equity well yet. We're still trying to get there. So I think that it's important to constantly reframe and say, we're going towards that. We are not at that space yet. And it will take continued work. Specifically why now and why this work is because of these three things that we talk about, right? Anti-racism movement pushed forward in the last 2 years, where we acknowledge that racism is systemically baked into the medicine that we learn from the moment we decided to be physicians, right? Every single course has some element of it, to the fact that none of the institutions, for the most part, have the names of people of color across them, and even the studies that we are learning our practice from don't count to include equity in terms of the populations. Then the fact that we don't have very bountiful DEI projects. In fact, often it's the same people doing the same work, and that gets compounded. And then finally, the restorative justice process, where we actually have the healing, where we have the acknowledgement and the ownership of what's occurred in the past, and then trying to move forward together with equity-informed steps. These elements are a part of that, I would say, reaching towards true health equity, and if we're not prioritizing this in our institutions, then we're doing ourselves a disservice in terms of training learners. So I'm gonna go into this next part and I'll pass it over. everyone asked about what health equity rounds was when I first saw it. It seemed pretty intuitive because most people have done something like that or heard something like that. It has roots though. The literature behind it, pretty clear. There's 3 folks that I think have to be credited with starting to do something like this and studying it. First, this article by Burgess, and then second, this one by Sukhera, and then this last one at the bottom, which I'm gonna focus mostly on, by Perdomo. So I think in 2017 is when it came out. Major point here is they were working with pediatric populations. They wanted their pediatricians and their residents to understand the differences, that exist in terms of health disparities and how to be better clinicians. And so they started to train them on understanding implicit bias and how structural racism affected the health outcomes. And they did this through a series of rounds. They had maybe 8 or 9 very clearly identified cases. They used the same methods and models that we do in terms of our didactics, except for not focusing on a clear clinical pathway. They focused on a health equity tenet, and they amplified that. And they found that these residents were learning more about themselves in the process. The most exciting part was at the end, they actually proposed solutions, and they followed through those solutions. So this is the backbone of health equity rounds. That's where the name came from. It focuses on these 4 ideas. Motivation. This is the motivation or ability to want to change something by providing the evidence of what happens when it's not changed, right? And you use literature or a case as the study for that. The information. This is where they have the concepts and the history behind whatever that tenet is, so it makes it a little bit more apparent and it connects the dots. Then there's the emotion. This is the engaging of others in a space that is safe so that they can self-reflect and learn from perspective. Then there's the orientation, which is, again, introducing new skills or some opportunity for self-reflection while seeking the brainstorming element. So I keep showing these slides essentially as a way to orient you to what we're about to do. So the traditional approach based upon that most recent article I showed really functions as 4 things. The first part, you're just having a lecture, standard formal style lecture. The second part is where you weave in the concepts and the framework. The third part involves specifically breaking down a case. And then the last part is thinking of mitigation strategies. So how can we improve based upon what's learned in the case? When it comes to doing this, what I found most helpful is starting this little pathway. You set the tone from the beginning. Establish safety. If you hadn't noticed, I started the same way. We start with setting the tone, making sure that others feel like this conversation is above the table and everyone is at the table. You acknowledge your biases. Then you state the learning objectives. Again, what I mirrored or modeled at the beginning of this lecture. Then you introduce the framework, which is what we're doing now. We'll move to presenting the case, where you illustrate the case, give details, and do a guided imagery exercise. All of these elements help to make the case real for the learner. During the reflection portion, this is like taking inventory of all the different biases in the room and trying to normalize the experience that, yes, this is something that actually happened, and you have a particular visceral feeling from it, but also trying to center the patient in that patient experience. You follow by building and fortifying with knowledge. So building the fund of knowledge by increasing their understanding of historical context, exploring those drivers that we talked about, and then really discussing and identifying those systemic and structural features that change the way that the health outcome is actualized. Then we finish by bringing it all back together. You synthesize it, brainstorm the solutions, and you change the course, you chart a course for change. So whatever was occurring before, how can we move beyond that? How can we alter this a little bit? There's another model that's very similar, space, quick mnemonic. It's doing the exact same thing, shorter amount of time. So the previous one I showed, maybe about 60-minute conversation. You can do this in a bedside talk in about 15 minutes, 10 minutes for like a morning report style lecture. Same concept. Share, then probe, acknowledge, connect, and engage. It's the exact same thing as what I said here. You're going through the same pathway, just a mnemonic to help. We're going to talk about this in our second half. All right? I want to give Will the stage to tell you about some of the things that our learners shared with us after doing health equity rounds.
So these are quotes from our fourth-year medical students who are going into EM over the span of a few different sessions. We'll talk about ways of evaluating these sessions in the future, but for this case, we did something called Appreciative Inquiry. If any of you have heard of that, it's a way of evaluating something by asking not like what is good or what is wrong, but what are the things that you appreciate about it, what would make it a little bit better, etc. How do you defend this class as being integral to the curriculum of the month or the year or whatever? And so we had really good feedback. People really appreciated this space, and a lot of comments for Dr. Brown as well. I like that there was room for personal experiences to be shared and for true conversation to be had around these issues. So people really are looking for a space where they can talk about this kind of stuff. We had an excellent conversation in examining social determinants of health and their impact in the ED. The process we used to evaluate each case was very helpful. Simply having open dialogue and understanding how similar scenarios are approached differently is extremely valuable. It helps us assess our actions in real time during our training. This session allowed us to explore the hidden curriculum of medical education and to genuinely delve into the aspects of providing care that are the most difficult. If we truly want to be clinicians capable of providing holistic care, we need sessions like this to explore our own bias and to learn from the experience of others, even when topics might be uncomfortable or challenging. And I think that's as well put as it can be. So really great feedback for us, and I'm proud of our learners that they were able to come to this. I think, we didn't have really anything in terms of negative feedback, which is always good, but it was a lot of, I wish, some of this was in Zoom, so I wish we could do this in person. Why aren't we doing this every year, every month? This is the first time in med school where I felt like we've had an open conversation about these kind of issues, even though there's a lot of lip service of we do DEI things. This was an eye-opening experience for a lot of people, and that this is where we actually had the conversation. So I think it was super valuable. Yes?
So is this part of your clerkship, like the rotation in emergency medicine, or is this part of the overall, within the construct of the fourth year medical school curriculum, this is where they get part of their health equity rounds training?
Yeah, so this was separate from the med school, although Dr. Brown does a specific thing for that. But for our purposes, or for my purposes, this was part of our away sub-I. So this is interesting in that we had people from 7 different schools, 12 learners from 8 schools, including some Stanford and non-Stanford students going through this together. Yeah.
That was my next question too. So when you have different learners from different med schools, because I'm thinking from a resident perspective, they're all coming from different medical schools. What's your experience with their level of knowledge of basic concepts prior to starting to have the conversations?
In terms of the foundational stuff that he just went through.
Exactly.
I don't know. We didn't do a pre-post survey in terms of what's your familiarity or to find these terms, although that would certainly be interesting. It was more of the concern that we had was, would it be a safe space, a psychologically safe space, and there was no problems with that. And then it was interesting having people come from very different training backgrounds. So Stanford is a unique place for many reasons, but if there is anywhere where, health equity or disparities in socioeconomic status is apparent, it's, in the area around where we live. And so Stanford has interesting things, but, that's present in a lot of academic institutions where there's a wide gap in the, type of care that people receive. And then just geographically interesting as well. So it was good to have such a wide variety of students do this. And I think the conversation was different than if it had just been all Stanford students, because different experiences.
And I think to that point too, so we have only implemented it with the sub-Is currently, so both Stanford and non-Stanford. But the goal would be to work it into our core and make it in a process that, like as I mentioned, all the Stanford students end up going through. The reason that that hasn't happened is that since we're off cycle a little bit, the sub-Is start in July usually, and we've been going through the process of just establishing our core rotation. It hasn't worked its way in. We do touch on the social drivers in the core as well, and hope to make health equity rounds a part of the core so that all of the Stanford students rotating.
I can talk to a couple other pieces real quick. For our residents, we give 3 health equity rounds lectures a year. So we've seen how they respond to those cases as well. And for the entire medical school curriculum, I happen to be a part of the team that's revising our medical school curriculum as well. And we've made it so that clerkships, for the last 6 months, there have been 3 clerkships that pilot the same exact stuff we're talking about today. Surgery, family medicine, and OB. And we've extended to pediatrics, internal medicine, and we're going into one more at the end of this month. I just forgot what the rotation is right now. But the model itself is what we're preaching, is like, hey, knowing that people need didactics around this just as much as they need to learn how to manage patients is important. So I've seen pretty good responses. They're always around the same tone, like, we need a space to talk about this. I want more. Almost like uniformly.
And as I'm sure we'll kind of review today, there are, essentially infinite circumstances in where this is interesting and that you need to confront. And so, even from our own, a number of sessions, we've had completely different conversations. It just depends on who's there and kind of where the conversation leads. And people, as we will see, are bringing their own, cases and their own concerns and their own thoughts into it. So it remains interesting for us. We're not having the same conversation every time. Yeah.
But it seems like what I'm hearing is that kind of health equity around is one piece or a tool or a method of education for a multimodal approach to topics within DEI. There has to be some foundational didactic lectures in addition to, say, providing rounds like this.
No, I'm glad that you say that. One of the things that I really like about this is that you can set the tone, like in that portion. So you can use the beginning of health equity rounds to give people the language primer, right? Just like the way that this lecture today, this conversation is structured is the very same way I would do it with residents. The same way I would do it with anyone else is I would give them the language up front, and then we do the exercise, and then we do the reflection at the back end and do the context. So, I'm telling you that there's opportunity in this model to do exactly what you're saying, to get everybody on the same page to understand the foundations of it. You can do it in the beginning or in the contextual portion once the case aligns. Because you'll see that as we talk about this case, each one of you will have a moment where you say, well, I remember this, or I felt this way. You'll want to know how you express that. That's why the primer is important. So I want to jump right on into the case. This is going to be a real group experience. Again, we've set the tone a little bit, so without further ado, I'll let Moises take over. This is exactly how we would do it with our students.
Okay, so again, as a reminder, and what we would do with our own students is trying to familiarize them with what we're going to be doing. So they do get a heads up. This isn't sprung on them. This isn't a surprise. We're hoping that they come into it with a mindset, even if they don't feel as ready, that's encouraged, right? They want to come in with their biases, with their maybe misunderstandings too. And so we want them to come from their different perspectives. So I'll remind us here that we're going to go through this exercise as a group. This is hopefully an experience that allows us to open up to the topics, open up to the experience. You'll notice that there's a little bit of instruction and guidance. There's also a little bit of self-reflection, some introspection, and hopefully some sharing so that we all come away with something as a group. For those of you in the educator mindset, you'll notice that at the very beginning there's a little bit of somewhat, maybe most familiar with like the 1-minute preceptor where you're gauging where your trainees are at. And from that, as Dr. Brown said, you are able to then facilitate a little bit better, right? If you do sense that the group is a little bit further along, you can go into like some, you can jump into some stuff right away. But if you sense that they need some foundation, then you start there. And so, as with any great sort of workshop or presentation, you're always going to identify your objectives up front. Make sure that your learners know where you're heading and where you're trying to take them. And so we talk about how we're going to identify and analyze some of the effects of our own implicit bias, but then look at some of the structural racism that exists in some familiar clinical scenarios. What we're going to do today is talk about some of the historical context that might exist in patient presentations and how that might impact their progression through a healthcare visit, demonstrating what might happen in the overall healthcare system. And we're going to try and discuss, as part of the workshop itself, the health equity rounds, some ways to mitigate and address this bias, using some of the strategies to combat not just our own beliefs, but what sort of we work within, right? Because it's also about the institutions and the structures that we're at. Again, these are just the disclosures. And so the ground rules: participate freely but respectfully. Acknowledge that we all come from different places and bring different perspectives. There's no blaming or shaming. We're all here to learn and grow together. The hope being that then we apply what we take out of this health equity rounds to our patient encounters, right? So that we make our clinician skill set a lot more empowered. And so as with simulation, for those of you that are into simulation, there's always the core belief that we're all here for bettering ourselves. We have the concept that we're all smart and skilled and we're competent, and so we will treat each other with that understanding, and we're acting in what we hope will be the patient's best interest. Of course, the cases themselves have been developed for the health equity rounds from true encounters, but modified to be more instructional. Another reminder, again, as Dr. Brown said, this is what you're going to get during the health equity rounds. You tell the trainees this is what we're doing. We've seen this already once as part of the workshop. Come on in. Yeah, no, the more the merrier, for sure. And so for those of us joining us more recently, we're going to be going through a case experience that would be part of what a health equity rounds would look like for our trainees. We ask that you be respectful but participate freely, and try and focus on the things that maybe we as individuals need to develop and learn from the sharing that the other participants have. We start off today by asking you to collectively, but then also individually think about your values. This, whether you realize it or not, your values are directly connected with your biases. And it's oftentimes difficult to tease them apart, but they do influence each other. And so I want to ask the group collectively, and again, please share freely, why did you initially decide to practice medicine? What were some of those concepts and values that brought you to medicine?
Sorry, we all family in here.
So for me, one of the main drivers was knowing that exactly these social drivers that affect our health prevent a lot of people from being healthy, and the fact that they're not able to be healthy to their best prevents them from getting the certain jobs they want, having the fun, having an experience they want. So for me, it was that ability to help take care of people medically allows them to achieve those opportunities.
So for many of us, it's going to be a understanding already of how there are external drivers to the life course of a patient, right? Not just sort of the times that we see them within healthcare, but everything that happened before and that will happen after, and the enjoyment that they have in their lives with their families, and trying to impact that, for sure. Yes?
For me, it was quite a different
But what I'm getting from you there is a very common theme, right? People say medicine allowed me to bring together a lot of what I considered interests or even strengths that I already had, and drive towards like a purpose, a common purpose, in the realm of providing a service, right? And so if I could bring your interests and your skill sets and into the discussion here, you found a way to meld them all together.
Oh, and one other thing. I come from a line of artists, and I realize that art doesn't pay.
That's a big one, right? Unfortunately, I wanted to be a teacher, and I recognize that education. I can get that in medicine too. You know, I can get that. Anyone else? Right, right. As clinicians in an acute care setting, and specifically in the emergency department, we very clearly deal with these issues of patient care and these considerations of family life and other on a regular, right? This is something that we deal with, and so it does bring it all together. Yes.
So I'd say it was during my undergraduate career that I kind of started formalizing my interest in, I didn't have the words then, but it was health equity, because I was learning about these disparities that we see, and realizing that a lot of the times the people who were experiencing those disparities looked like me and people who I love. And I had personal experiences with discrimination and knew that that played into those disparities, and just felt this really deep sense of it not being fair and me wanting to do something about it, and realizing that medicine is one of those places where those disparities show up in a really real way, so that I can use medicine and my role and the power that I have as a physician to do something about it.
Absolutely. So there's a lot of overlap here, and hopefully you guys are starting to see too. So we're exposed to these things, we choose to engage with them, and then we use our skill sets and our interests to try and address them. Absolutely. Jen, I think you had your hand up, would you?
Yeah. I previously worked in health. I'm a medical student. I previously worked in health consulting and then decided to go into medicine because I felt like, yeah, this is something where I can go to work every day and feel like I did something positive in a very tangible way. And then someone quote was before emergency medicine appealed to me because it's like a place where everybody can get care and it's not, I think, to treat people with dignity. Which is a very nebulous thing, but I think really important.
Yeah, we're challenged with seeing people at their worst, right? Whether that's physically worst or mentally worse, or just sort of overall a low point in their life, and we apply these things. The next step in trying to grab a collection of values would be to ask, as a physician yourselves or as a budding physician, what are your values and what do you value with respect to providing patient care? And how is that slightly maybe more defined or different than what we just shared? As a physician or a budding physician, what are your values? What do you value with respect to caring for patients?
What I value, and takes time, is trying to figure out what the patient really is there for, what their real motive is, not their stated chief complaint. And I found sometimes very big differences between the chief complaint and what's really troubling the patient. I'm sure all of you experience
So it's about really getting to the need for that specific patient encounter amidst the noise that might be going on. So if you value finding that core interpretation of it. You want to fix, you want to do, you want to get at what's actually desired. Mm-hmm. Yeah. Absolutely.
So I think that's something that I've been learning as well as, you know, as a medical student and a resident, that one of the reasons I got into medicine was I think the intellectual challenge. I enjoyed the problem solving, and I thought the emergency department was the best place to do it. And now as I like transition more into being an attending for the last couple of years, it is a lot more apparent that the intellectual challenge is not necessarily, you know, the 5,000th chest pain patient, but it's how do you interpret the results and figure out the specific anxieties of the patient and communicate what you found to them in a way that's culturally sensitive, and then also that has, you know, reasonable next steps, and how do you plug them into care. And that's what I spent a lot more time doing as an attending, is following and kind of cleaning up, not necessarily poor care, but, you know, potentially poor communication or misunderstanding. And so that's my, you know, my preferred intellectual challenge now compared to, I think, the actual medicine. In a way, you know, when I don't have residents or med students around, I still like the other stuff. But, you know, the medical care becomes a little more routine, but I think social care is infinitely different and interesting.
I'd say in the beginning, if I were to be asked like what I thought when I was going into med school, I'd say that I wanted to give the absolute best care, as if there was some finite best care that one could get, you know. Versus now, I think as an attending, I just feel like I spend a lot more time with patients, where because my residents are kind of doing everything else with the patient's care, I have a lot of time more to reflect on like what does the patient want out of their visit that they're there for today, and I think that kind of gets to her point also, is what's the underlying reason, but also, you know, how could I best serve you today, and what your experience or what you want to have achieved today. And sometimes it's not giving them a medication, sometimes it's you know, helping them navigate the healthcare system, or what I hear a lot at my institution is they tried forever to get to see a consultant, they just couldn't.
And they
you
show.
know, what I'm providing today is, listen, we don't have to do any labs, I'll just get you into a for appointment, I can call someone down to see you. That's the best thing I can do for them that day. Even though it's not the best care that I might have thought of when I was going into medicine, but now for me, kind of making that shared decision is what I find to be the most highest value.
I just want to add one point. I try to sit back as much as I can and just observe, because this is really beautiful to hear. I couldn't help but mention my own trust is huge for me, you know, from a cultural standpoint, and then as a provider. Like, I want my patients to trust me, but I also want members in my life and my family to trust me and feel trusted. And so that's driven a lot of my goals for care in terms of how I establish a relationship with patients, and something that I've highly valued over the course of my career and just with relationships in general. And so I think it's interesting that has bleed over into my clinical practice and how much trust matters to me. So I see myself in a room trying to establish some type of trust with the patient, and I want them to feel like what I'm telling them is accurate and actual as best as I can. So I do my job to make sure that that's a part of the social contract that's created between us. And that's just my personal value system. So.
Absolutely.
So for me, one of the things I remember from early age is learning the golden rule back in second grade. I remember exactly the moment learning it. And I think it's so cliche, but it's one of the biggest factors that affect how I treat others in my social life, in my personal life, and in my work life. And I try my best to maintain that and then treat others the way that people treat
And I think you're hitting on something really important there that we hope to demonstrate as part of the health equity rounds is that pause and reflection, right? I've mentioned we're going to do a lot of reflection. But there are many times in the ED where we have to purposely choose to pause and slow down, right? And it's these values that we're identifying that you might find commonality with, not just in the why did I go into the profession, but why do I do what I do, that is helpful when you need to take those pauses, remind yourself of what you were doing. I saw a hand up back there. Yep.
I think just expanding on something that you had said about trust. For me now, when I see a patient, I want them to feel that I have heard them and that I value them. And that when they leave, regardless of whether they have the right diagnosis or medication, that they feel like it. I knew that it was important for them to come to the emergency department that day.
So sometimes the difference between an encounter and an experience, a visit versus a conversation, right? Like sort of building on not just an exchange of services and goods, but more about the humanity underneath those conversations. Yeah. And we'll take one more. I think you put your hand. Yeah.
I think I saw emergency medicine as this diagnostic challenge. Now I see it as this kind of practice of standing in the gap. And we're doing a lot of things that aren't things that necessarily taught to you. We're dealing with the system. Things are kind of shoved upon us. Like it's not our fault that these patients don't have follow-up. It's a history, and we understand some of that. Maybe you don't. Bring to bear power that we have. Whether or not that power is the fact that we have this just from a historical sense, not here or there, to try and get what we can do to kind of correct what the patient is coming to us with. And sometimes that's a diagnosis, and having medical knowledge is important, but seeing the entire history, I think, is what we do. And I don't think there's another specialty that has the same burdens that we have and responsibilities, and at its best can change. You see people at inflection. No matter what they come in, they think it's the worst day of their life.
Absolutely.
And there's an opportunity for change there. And sometimes that means moving a system that doesn't even move that way and having the finesse to do that. Staying in the wood.
Yeah.
I think that's pretty good job.
Yeah. No, I like.
I hear that.
Yeah, I was gonna say I like how you're saying, we've sort of bridged this gap, and it's lots of gaps, right? It's gaps in different ways. Sometimes it's with one type of issue, other times it's with the other. The last shift I had before with residents before coming back coming to the conference was with off-service residents. We have an area in our emergency department that the interns there are all the off-service rotators, and at the end of the shift, it was a great shift actually, a lot of different pathology. One of the medicine interns just looks and goes, I didn't realize you guys dealt with so much of the red tape, and you guys are making 3 or 4 phone calls for each patient, and you're sort of thinking long term. She's like, we just thought you triaged, you admit and you discharge, right? And I was like, yes, thank you. That's the point of you rotating down here, right? So that next year when you're taking my phone calls and I go, hey, I tried everything I could down here, but I think this patient needs to come in, that you remember we've tried, right? It's been six hours that we've been trying down here, and we've come up with the next best step, the next best. It's not the best, but the next best. So what I've heard so far, and I want you again to keep these values, the collective group values, but then also thinking about maybe the values for yourselves that you didn't share in mind as we move through the cases, right? The fact that we wanted a challenge, and it's a challenge not just intellectually, but about sort of navigating the healthcare system as it exists, acknowledging that there are life stressors that factor into why they're there, that we sometimes don't find the best answer, but we try and advance that patient's care forward in some way, shape, or form. And it's about those conversations that we have at the bedside, making them feel heard, getting to their true concerns, not just what the chief complaint was written as by our registration. So we're going to talk through some cases, and these will be examples of what we use in our health equity rounds. So as a primer, case 1 comes in and is labeled as a chief complaint of chest pain. take a few seconds, sort of start to think in your mind what that might mean for you. Some more information about our patient A, just in case number 1. Their arrival time is documented as 4:28 p.m. And this is a 36-year-old male who presents to your emergency department with a chief complaint of body pain times 3 days, but I think someone identified the chest pain and wrote that out. They have a past medical history of sickle cell disease and have hyperlipidemia as well. They've had a surgical history of a splenectomy at 12 years old, and you have your triage vitals provided to you on your little sort of patient note. I'll let you review those. I want to give you some time to reflect on that. You can close your eyes and sort of, if you've had something similar come up in your when you're working your shifts, and try and picture yourself in that situation if you were to be instructed about this patient. And then you also have patient B, arrival time of 6:16 p.m., who arrived after a call from their primary care physician notifying us that they were coming. 32-year-old male with a chief complaint of chest pain for 2 days. History of cystic fibrosis and bronchiectasis, and their triage vitals here. You can sort of close your eyes and envision yourself if you were the receiving doc of this patient. Start thinking about sort of your personal responses, your feelings, your anxieties, maybe even about caring for each of these patients. The concept of presenting these patients and allowing you to close your eyes and envision yourself in the situation of the provider is to try and elicit maybe some familiarity with cases that you've had before. Right? So thinking about the situational awareness that you would have had seeing patient 1 show up and patient 2.
Did anybody else, when they visualized this, did you hear the sounds of the ED? Did you hear the sounds of other patients? Someone down the hallway asking the nurse for something? People giving you an EKG while you're trying to focus on this? Like, did you all visualize that? It helps paint the picture for you.
I knew the 2 patients.
See.
And there's other stuff that sort of comes with it too, maybe some reactionary like, that phone call from a PCP, right? How does that make you feel versus when someone shows up, say, by the ambulance, by themselves, different sort of things. Yeah.
Yeah, that's fine, but talk to me about this chest pain, about chest pain. Where do you get your earlier care when you were getting I know what they're like over there.
Yeah, no, and this is sort of where we're heading with this reflection, with this reflective process is I want you to get those gut reactions, right? And so you're wanting more info, and you mentioned being a fixer, right? And so I'm sure you want to know as much as you can to get to that point.
Right now, there's probably 10 possibilities for each patient, and I can't weigh them because I don't have enough information. Frustrating.
Yeah. So, take a moment again to just sort of reflect on that image that you created in your mind as you heard about those patients. Think about that that gut reaction that you had. So I appreciate your having shared where you wanted to go with that vision. Does anyone else have a gut reaction that sort of came to mind when you heard those cases and what you started to think about? Yeah.
Significant disparity in time between the first patient as a chronic and debilitating painful condition, probably not even in our eyes and triage and say they're both 32, they both have chronic conditions, but the first patient to be diagnosed to patient with stage 4 malignancy is sitting
Yes, you're starting to think about sort of even in just like all the possibilities that might be going on. Maybe we should have started this a lot sooner. Maybe we should have addressed things a lot sooner. Starting to think about the processes. Yeah. So there will be. Yeah, we will be. Mm-hmm.
The implication is that the first guy, because he has sickle anemia, is likely to be African American, and the second guy is more likely to be white, although I don't know that yet, because I haven't gone in to see him. And, but I know that the second guy has a PCP who wanted to call us. And depending on the PCP and the place, that could either be a hindrance or a help.
No, we're definitely getting to, as the cases develop, I'll present a little bit more about each of the patients, but you're already starting to anticipate some of the differences. Yeah.
But I would be unhappy with myself if I had not seen that sickler pretty much immediately on arrival, or the bronchiectasis patient.
Mm-hmm.
And in 2 hours between, surely I would have had time to involve.
Yeah. Yeah.
Or my resident, or my medical student.
Yes, back to you. Uh-huh.
So I apologize. I was not trying to generalize my own feelings to anyone else in the room at my facility, both patient pool. It would be fun for me to run the board and see the patients and have a vote.
No, yeah.
Feel pride in saying
No, I appreciate your apology, although it's not needed in this setting. We are trying to get to a point where there will be a time difference, and so I think you're sort of already anticipating something that we've seen, right? You're anticipating this because you've seen the differences, and you've anticipated the issues when you go, oh, right?
I'm already hearing my nurse sing another sick
Okay.
That's the visualization.
Thank you. And see how each of these sharing episodes is taking us to where we need to go, right? Thank you. Yeah. Now we're starting to unravel, right? Like, so we're all having these feelings. Absolutely. We've all visualized this for sure. Yeah.
My first thought was actually like, who's on earth? Like, who's my charge today? Because it's like, you know, is it gonna be the one that I have to like fight with to give medication to this patient? Am I gonna have to go back and forth? Like, that was the initial conversation. Probably some early anger, but it was, oh, okay, this is gonna be mobilizing the team. This one probably isn't because there's someone who's called in, being mobilized without even a arrival note or call or something. And so it's immediately that deficit is working because of systemic bias and presence. It's like,
I'm just going to mention this is a pretty advanced group, but you can imagine, you know, a first or second year med student, they have no idea of the social and cultural implications of these diseases or the history of them, or even necessarily the, you know, genetic contribution. So it's interesting to see, because you guys know, I mean, you've seen this, you know exactly where it's going, but some medical students are like, okay, you know, like they're thinking something completely different because they haven't seen it in practice yet, or they don't necessarily know. And I think these are some, you know, 2 very specifically chosen diseases, and you will see why, but I think it's fascinating how quickly you guys, but these are the problems.
Yeah. And I'm not even mad, right? I'm not like, oh, they jumped to the, no, it's because that's the point of this, right? We presented you with the stimuli, and your mindset, your heart, your thoughts, like all went there, right? And we're aligning pretty well.
But it's not just positions, right? I mean, just culturally, right? In every aspect of just society, everybody knows, right? It's not discussed about the consequences of having sickle cell disease and how severe it will be. So
And that last point there, I definitely want to remind us to come back to later about the sort of like foundational information just provided globally, right? So we'll come back to that for sure.
And I found what's interesting about this too is like both chronic conditions, and I know now reflecting on it, in one case I'm going to go in and I'm going to be told of how I'm supposed to care for the patient based on, some kind of prior memorandum of understanding with another crew. And then the other one, the patient's going to be telling me what they're supposed to be needing and how best to manage them. And I'm going to follow theirs just based on that scenario. So.
This is really interesting. I mean, just with you all and hearing your responses and how you guys literally just navigating the case without us going there.
Yeah.
Next, we can go.
We do this. Yeah. And this is the space and the knowledge that we want to bring our trainees into sooner, right? Like we've all gotten here because of our experiences, and we want them to deliberately experience these in a setting. So you would have seen me go then to the next slide, which would have told you a little bit more about patient A. Remember the patient with the total body pains. Discussing more about it was a gradual onset, but worst in their chest, and that's highlighted with their chief complaint. Moving to their lower extremities, daily medications without improvement of their symptoms. And if you choose to sort of close your eyes again as I read this out, you'll hopefully sort of find the story developing. So it's atraumatic, no clear trigger, similar to prior episodes, prior hospitalizations. There's no fever, no dyspnea, no abdominal pain, no change in bowel or bladder habits, dizziness, numbness, rash. They have a cough, they have the joint pains, but they're otherwise not endorsing anything on review of systems. And on your physical exam, what you do identify are some right lower lobe crackles on their lung auscultation. So kind of envisioning this patient now in front of you as it develops. So, and this is them in the room now at 5:35. Second patient in the room, 6:37. Their pain was gradual onset as well, chest pain with dyspnea, similar to prior episodes requiring hospitalization, cough but no purulence, otherwise normal review of systems. And when you listen to their lungs, you have bilateral decreased lung sounds. There are some bronchi present as well. So since, as some of the things that you've identified already as differences, we choose to highlight for you so that we can all stay on the same page. The ED course has been different, to put it just simply. It's been different. Right? Patient A roomed an hour after arrival. Patient B roomed 20 minutes after arrival. When you look to see what happened for patient A, their pain meds were ordered after being roomed, and their initial medications were Tylenol and Motrin. Patient B, pain meds ordered from the lobby, with the initial choice being IV opiates. And then the rest of the course developing even more differently. Patient A requiring repeat doses of, by then, opiate medications and eventually being admitted to hematology after a 3-hour and 52-minute stay in the ED. Patient B admitted to the cystic fibrosis service less than an hour after arrival. Yes?
What's the justification for giving Dilaudid to a patient with cystic fibrosis? I would have thought antibiotics and nebulizers would have been more appropriate and maybe effective.
Excellent point.
It's not meant to include all aspects of care here, just the differences in treatment in terms of what would have been offered to both.
What I will say is similar to your point here is where sometimes patients are more informed. They've had previous experiences, so when they come in, they'll say, I usually get 2 milligrams of Dilaudid for this. And they are believed. That's really a part of the story.
And that's definitely where we're heading with the, highlighting the salient points is that we want to ask ourselves to look through the lens, not just maybe of the provider's maybe the system, all of the contributors to their difference in care. So it's very similar to what Dr. Brown is saying, perhaps patient being more informed or more vocal about what they are requesting. But what other things factored into that difference?
I think it's most likely and they were believed part.
And they were believed.
I'm just going to speak on that for a couple seconds.
Yeah.
I mean, there's obvious stigma around sickle cell disease to the point where some patients will come in and they assume that no matter what they'll say, the doctor's not going to listen to them. And so they'll sit there in pain for literally hours and will continue to decompensate in terms of their own health and will while someone thinks that they're treating them appropriately. Whereas some of our cystic fibrosis patients are empowered and are told earlier in their lives, like, hey, you speak up, you say things, like I'm still in pain. And there's implicit bias among providers, implicit bias among admissions algorithms that literally amplify that belief. And so we'll talk a little bit more about that now, but it's just very interesting to see how the time differences pan out and how this is an experience that each one of us in this room can say, like, I actually feel like I've seen that happen. Like, it's not made up. Can't gaslight on this. This is happening every single day in every hospital across the U.S.
Literally my last shift had a patient, we have this kind of standardized ED airplane. That's the idea, but it's not in all of the charts for each patient, unfortunately. But even with a standardized ED airplane, everyone agrees, your hospital is ED, okay, patient. That's diesel doses, it fails at missed. We had a case like that. All the ED airplane, African American woman who has a lot of pain crises, called the hospitalist. Hospital said, I'm not going to admit this patient because she's been admitted 2 times. I'm like,
So you said, when you're thinking about these patients coming in triage and like, oh, they've been here 3 times this week and they're here again, like that's a bad thing. Like that's clearly some need is not being met from, certainly they might have had a workup already, but they're not better, right? I think that's such an interesting reaction that people get when, people are presenting multiple times to the ED. Not, oh, we have missed something or they need something more. It's why, I can't believe they're back again. And it's like, it's just such a, same thing. Like, I can't admit it because they've been admitted too many times. Like, would you say that about cancer pain? It's just it's fascinating.
What's funny is when you all did the visualization exercise, how many of you all saw a black patient?
Yeah.
What if I told you the patient was Dominican? Dominican. But I'm just saying that these are the way that we approach our lives.
Let's do it.
He was actually not a dark-skinned Dominican person. He's black. I understand. Essentially, the teaching point from that is a lot of times someone that does not phenotypically appear to be black, we will push this disease on them. We'll say, oh, there must be a black person. They're not always all someone who phenotypically looks black. I trained in the Bronx. I had so many people who were not phenotypically appeared black, had sickle cell disease, and also got treated the exact same way. So it's very not matter.
It's, absolutely.
Right. So, but yeah, I bring that up essentially because we almost always see a white person for the cystic fibrosis disease, almost always envision a black person for sickle cell patients. However, they cannot be, you can see it different. It doesn't have to be the same image every time.
I
Yeah.
was going to say that one of the things that's challenging about this is that we're inheriting a system of practice that developed in the midst of the opioid crisis, the opioid crisis. EDs want to be responsible, and then we walk into this, and there are unconscious scripts that maybe no one's ever heard out loud. So, we don't want this person speaking on addicted to opioids. This person's been on opioid medications, only taking IV opioids, basic medicine, okay, these are two independent disease processes, but appreciating that each disease process has a script, and you have to unlearn that script to be able to treat these people equally and understand decades of history that came before you even picked up a stethoscope. That's what you have to start with, because you're not starting with equality and parity at both lines, and that's a huge responsibility. And that's not, I think, appreciated enough that educators have to provide that information. While battling people saying that we're politicizing the practice of medicine, while also teaching good clinical skills, while also teaching good exam skills, while also teaching good interview skills, while also dealing with the healthcare system that's more involved with providing billable care than providing healing services to people. I mean, that sounds like a life's work, and I think for a lot of people it is, and it's not to be discouraging, but appreciating the mountain you have to climb is important for being able to climb it. And so when you talk about Puerto Ricans, I think that ends up being rolled into this idea of like there's proximity to blackness. Yes, they may not be phenotypically black, but the minute they open their mouths or the minute someone looks at their address, if you're in New York, I'm from Miami, I can tell you where somebody's from. When they open their mouth, I can tell you what island they're from, right? Like, so that locality is still proximity to blackness, it's still anti-blackness that pervades everything we do in the history of this country. When you walk out the door and you decide to go to the Dollar General, or you decide to go to Trader Joe's, you're going to see that. I agree. Yeah. It's conditional.
Absolutely, absolutely. And sometimes you're right. So these are very like concepts that are like pervasive, and for some of us we've dealt with in different levels. These med students that rotate and do the health equity rounds with us are going to be coming from the different experiences as well. Sometimes the clearest example that we can provide them in the discussion is what you brought up about how like there's advertisements there for medications. CF gets its own like foundation commercial. It gets its like raising awareness gala, right? And we grow up even before medicine, right? We see these out on a poster somewhere, or we hear about it in the background while the commercial's running, right? But how many times do you hear about sickle cell as something that needs to also develop awareness, get fundraising, whatever for research? So it's not to use the word like indoctrinated, but like if it's all happening in the background, and even before we get to medicine, we already are familiar with cystic fibrosis as this like thing that is important because it makes the news or it makes the commercial, and then the first time we hear about sickle cell and the issues that come with it is not until later, then we're already behind, right? And so that's exactly, I think to your point, like I sometimes bring that up with the students as an example of like, look how behind we are, right? Like we haven't even encountered this in just general societal language and practices. And so, absolutely.
There are like survey studies of medical students and residents where just to correct like scientific misunderstandings that medical students believe that black people have higher pain tolerances, thicker skin, like things that are just like, scientifically inaccurate. And that's something even before you get to the social, circumstance of who is deserving of pain medication. Like you said, I like the way you put that. Like it just is, you have to start basically all the way at the back beginning in some of these circumstances.
Yeah, and because we're at an advanced group, I think we can have a lot of these discussions more freely. With the students, as we'll talk about a little bit in the last half, will be about identifying the discrete and the concrete things that we would address and bring up, so that we don't maybe create more confusion, but at least give them something to go off of.
We can go through some of
Yeah.
this. We just talked about this.
We've done. Yeah, you guys are on such an advanced level, right? So,
The main thing about this slide essentially is realizing that this discrepancy occurs in a variety of other spaces where implicit biases are affecting the way that care is delivered, cardiac cath rates, novel cancer therapy, referral to transplants. Like you see this across all different spectrums, not just pain treatment, or like I think there's even a study that talked about where somebody is like synced in terms of hospital systems. It differs by zip code, but also people within the same zip code will get sent to two separate places if their skin tone is somewhere different. So, yeah, it's very, it is compounded.
you can just kind of click through some of those. Sure.
This was a study we did, or that some of our colleagues did at Stanford, looking at where and who was placed into hallway beds and for what reasons. And it does not generally reflect particularly well upon our department, I think, in the triage system that goes into it. But this is the important kind of self-reflection that people need to do.
I think this is interesting, right? The fact that if you track funding for cystic fibrosis and for sickle cell disease, like two total different streams, the amount of awards that are people that are given for research, NIH doesn't fund them evenly, and even when the researchers are people of color, there's a likelihood that they will not get funded for doing the same research. When someone who is of a different ethnicity who's doing that research they will actually be funded. And this is data that is present. I can share with you guys afterwards to help if you all want to do a case like this, but it adds to the clear disparities that we see. It's not just individual patient level, it's very much so system-wide around this particular pain control in these two conditions where they have very similar outcomes long-term and sadly have different stigma related to them.
Stanford has a cystic fibrosis admitting service. We don't have a sickle cell admitting service, right? And just from like that alone, this is going to be, yeah. It's folded into hematology, but yeah.
This picture, if you actually get a chance to read this article with this young lady here, she talks about the patient experience, and when you really go through how it's very, very heart-wrenching to hear, how many times they have been kind of typified as something that they may not be. I don't know if you're familiar with the rapper Prodigy from Mobb Deep. He had sickle cell disease. He wrote a whole song about it, and in every bar of the song, he talks about how much he almost hates going to the hospital because he knows that people are going to look at him like he's some type of dope fiend. And that's his lived experience. I don't know too many cystic fibrosis songs. I tried to find an appropriate corollary, but in general, I think that both are very terrible conditions, but to hear it repeatedly, how badly that they are looked upon is sad.
And then when you look at, if you look into other people's records, or sometimes, certainly as my own growth of position, into my own notes from when I was maybe a resident, just the way that people describe lived experiences of pain can be extraordinarily different and then cause bias the next time that person shows up to the emergency department, right? You have a difference between patient is in 10 out of 10 pain, patient claims they have 10 out of 10 pain, right? Just things like that. Demands opioids, right? Or,
Or even, I've seen, we used this term a little earlier today, sickler. I actually do not agree with the term. I think that the term itself creates negative stigma around the condition, and it somehow removes some of the humanity from the condition itself. But that finding itself into a medical chart from the first thing, 40-year-old sickler.
But you don't know.
That's not a great statement.
You don't know. This is something that's been passed. We're talking about generational, right?
Sure.
I mean, that's how we sat in medical school learning about sickle cell disease. This sickler right here, and they use so in fact, like we're all guilty of it until you know better, right? You won't do better. Sure. And so this is where it can't just start with it has to start like when they walk in the door.
All right, so I'll take a breath. We got it. I feel you.
You have to start getting this out there.
Absolutely.
So people start thinking differently.
Yeah.
I mean, just the fact of socialization of just medicine in general. Like when I'm into medical school, I'm the only black person sitting here, and the next thing out of somebody's mouth, like, you're here because of affirmative action. And I'm like, what? Like, so this is how just society-wise we've all been conditioned, and until really medical education in general, makes this admission, like, okay, we all know that y'all are brilliant people, but really y'all defective, and we here to fix it.
I think.
And start from there, right, and just bring it on down.
Yeah.
This-
I think you missed maybe one of the first slides, or maybe you came in a little after. I talked about the undergrad course that I teach, and how it's like freshman, sophomore, and they're already thinking about that, but they want more, right? And they want the course is you can only get 60 people every year, but I get asked at the end what should I take next? And I'm like, well, let's look through the catalog, and you're just like, it's kind of the same over and over again, but they want that more, they want it earlier.
And what's wrong with calling somebody a diabetic or a fibrosis?
I appreciate.
Rhetorical question.
No, I appreciate it. Thank you.
Or hypertensive.
I tend to try to use the phrases a person with. That's just general presentation etiquette at this point.
We tend to nominalize them with their disease. And even less so, let's go see the gallbladder 3. And since there was no heart, lungs, or that gallbladder just sitting there on the
It's
table.
just by itself on the example.
The 56-year-old cancerous patient, and that doesn't make any sense. So one of the other, so there's actually studies that show that if you present learners with two different charts, one written in a way that is intentionally stigmatizing and one that is not, they will, or residents, they will provide different amounts of pain medication to the exact same patient presentation based on the language in that chart. Went to McDonald's versus was able to eat. You know, like things that are just like completely, you know, the way that you write the information is stigmatizing. One of the ones that I've been watching out for recently, which doesn't necessarily have anything to do with race, but is obesity. And, you know, having obese in a chart as part of their one-liner, especially in the emergency department where no one goes to the emergency department because they are obese. Like, it's just, that's not why anyone has ever presented to the emergency department, and is almost never the cause of their presentation either, you know, even if it is low back pain or joint pain. Like, sure, maybe contributing factors, but like, that's not the reason that they have this acute pain. And so, especially now that patients can read charts, like, what is the, you know, there is no medical benefit. It is stigmatizing and it is harmful to the patient. And so it's something I've been really going through. And like, it's so easy to check a box, you know, on the Epic. Like, why is that even on? You know, you can see what their BMI is based on the chart. You know, you don't need to have that. Or even like, you know, in the psychological part of their chart, checking patient is tearful and anxious. Like, yeah, they're in the emergency department. Like, that's not part of like a review of systems that is useful to anybody, right? It's just, it's so interesting how easily these things get codified into the medical records.
A whole separate, definitely workshop itself, but how do you correct that, right? Like if somebody tells it to you, and what I've seen with at least the medical students that I've worked with, where I've had to correct some of the statements that they use, it's just, you know, you've already hopefully developed a tone where this is a month for learning, the things that I'm telling you is to make you better, and I try and phrase that too, and I say, you know, I want to call attention to something that you said and a term that you used. This is why I think it's inappropriate, and I would recommend that you use this instead, and hey, I just want to set you up for success later, right? So it's about having that appropriate, but like, correct, you know. But there's the, you know, how to do it is a whole other topic for sure.
Oh yeah. Adherent versus
Compliant.
Or like for sickle cell patients, I often see in my colleagues' charts, because you know they're there a lot. I read back and I see a lot of patient visited our department frequently, like in the last week, every single day for this same complaint. Well,
it's a microaggression against the
like,
patient.
yeah, it's like, yeah, exactly. Like, why is that necessary in the chart, right? You can say a patient has been seen here previously. You don't have to say every single, you know, like adding that extra language just makes my attending or somebody else's attending just be like, we only get 2 more from them around.
I think especially, sorry, as an attending where you hear about the patient first and then go see him, there is a lot of, you know, it's a very different experience as you progress of like learning about this patient and having to basically like stop and like go see them as a new person. You know, I just think it's the way that someone's described you is just, it changes a lot.
All of these observations are things that you can roll into the cases that you use for, say, a workshop like this. So I hope that you guys are kind of taking note of what's being said, because each of these in themselves is a way to differentiate, like, say, one patient from the other, one case from the other.
If this patient has been here every day for the last week, what the heck is wrong with you, doctor?
Yeah, what's wrong with their system?
Write the chart about how you screwed up, excuse me,
Same with the homeless population. I don't know, like, those qualifiers used to describe them, poor hygiene days.
everything that we talked about and the way that we're describing these, what are some things that we can actually do, like step or action-wise, to kind of like not have that happen? Like, or in this particular case, let's just say the two things that we saw. Is there anything that off the top of your head you're like, this is a potential solution that we could?
Gene therapy. Get
I,
in the house.
I get that. If we had the resources.
If we had the resources.
Yeah. You know, if we did, we could be a little bit more explicit about that. Unfortunately, it's going to take a lot more noise for people who are advocating to speak towards increasing funding, making it equitable. That's how I would approach that, is what are we doing in terms of lobbying for our sickle cell patients as providers? What are we doing in terms of enforcing or encouraging policy change and reform around it? That's how I would approach that. What would I do? I said, what are we doing in terms of encouraging policy reform? I said that's what I would do if at the level of like an attending or at the level of someone who can actually speak to the policies that exist.
What policies at what level?
Oh no, I'm talking about like national policy to drive funding towards it. That's how you would get more money for bone marrow transplants. Is you would need to have increased research, you have large scale trials, you have to have funding go in that direction. But I'm saying, what can we do even at the smallest level?
Departmental policy.
I agree with that.
That's empowered to do, whether or not I can change the dialogue at the Washington level, I don't feel it's sufficiently powerful to do that. But I can say as the mother of a person with a genetic disease, which is less than 1 in a million, our group is banded together with a bunch of others, and we have an organization called As Rare as One. And we are doing our best to get funding and support the 4 or 5 researchers in the whole world that are working on a particular problem. So there are things that can be done.
You're right about that. Right about that.
We do a lot of fundraisers like with, what they call it,
Like wormhole content. What's going on?
But like, let's say if I was giving this to a healthcare reruns to residents, utilizing some of the important factors that need to be done for them for residency graduation, I might say this might be a great opportunity for a QI project, or this would be a great opportunity for a resident research project to maybe look into understanding why it takes so long for this patient to be compared to these cases, and perhaps forming some kind of pathway to and studying that pathway to see if it affects kind of time to that this condition.
That's right. Exactly, 100%. Like these are the things that we try to elicit from the students. Like, oh, maybe we need a better algorithm, or maybe we need to review what are we using pain scores effectively? Does this even matter? Whether or not there's option for if there's a CF service, why isn't there a sickle cell service? And how do we advocate for that? Like these are the ideas you want to elicit from the group. But again, like I push people on, all right, so this is just a local. What about the next level? What about the next level? What about the next level? Because essentially what you're doing is helping them create that mental fabric and really reinforcing the skill sets of you as an ER physician. You can communicate, advocate, you have the insight and the background to support your statements, and you can identify surgically like where you can lay your influence. And so those are the things that we try to elicit from the group when we're doing this part.
And then remember, we haven't got infinite energy.
True.
We have to keep it that way.
That's like the main driver of why I'm spearheading the DEI curriculum at our program, and what my goal was to do. It's not a UI project, it's my scholarly project, to investigate our own niche, like departmental biases and our obstacles, because
So this kind of, this really going through this really gives you the ability in myself to catch myself, and that's, when you learn how to speak in a certain way. I mean, I tell my friends who have not gone through med school, you just basically learn a new language for 4 years. And if parts of that language are wrong, you have to relearn that. Okay, so we can talk quickly about kind of how we do a debrief. I'm sure a lot of you have some debrief training or simulation training that allows you to do a little bit of this. I want to say, we collect the values at the beginning for a variety of reasons, but really it helps people like solidify around a why. And so you're not having people argue different things than what you want to be arguing, which is how implicit or explicit bias contribute to care. You're not trying to have, people generally go into medicine for similar reasons, which is it's interesting, you get to help people, you want to make things right. And so this really unifies the room around these shared beliefs. And then for the visualization, it really puts this right in front of you. It draws you a lot closer to the experience, so you start to hopefully have the same feelings like a simulation of that nervousness, that maybe that anticipation. There was a lot of anticipation of what was going to happen with these patients just from the one-liner and the time to presentation.
When you said that comment about charging, I immediately as the bottleneck. I was like, yeah.
There are a lot of challenges to a health equity rounds workshop like this on an individual and a group level. On an individual level, a lot of this is dependent on the people who you're doing it with to offer their own insights and their own experiences, and so that can be hard to draw out. But that's why the tone setting is so important, so people feel comfortable to do that. And we'll break down a little bit of how you kind of work to develop psychological safety. A lot of opportunity for triggers, especially people confronting feelings or bias they did or did not know that they possessed. And so it's important to, again, be able to address those, let people feel those triggers, and then kind of talk about how you are able to offload that energy in a productive way. We haven't seen this, but there, I would say, is a theoretical concern for some retaliation, either from the people leading these or from students that you work with and that you're going to be working with. There's ways of students to give feedback to each other for a lot of schools. If I am your clerkship director and you're here trying to impress me, and then you say a bunch of things about your explicit bias, it's hard for me to not think about that necessarily. And so, I certainly haven't downgraded anybody on having this experience, but that would be a perceived risk. And so that's something that you have to really orient people to, is like, this is a session for us to learn together. I'm not grading you on any of this. And then, on an individual level, make sure that there is room for healing, so leave some time to kind of discuss the things that you can do, that you will be able to do. You don't want people just feeling bad about, the experience because they've realized they've made some of these mistakes, and go from there. On a group level, you really have to consider the setting and the environment. So we've done these mostly via Zoom, which is pretty interesting. I think Zoom does offer some particular advantages, is a little bit more dissociated. And then one thing that I like doing if I'm in Zoom sessions is I can have people write things to me on like a direct message in the chat, so not everyone sees it, and then I can read it out as like a comment that somebody wanted to say without necessarily having them have to say that aloud. So that gives a little bit of anonymity even within like a very small group. And then, there's always going to be things happening in the real world that impact how people are feeling about these things at that time. And so it's important to make sure that you are at least abreast of what's happening kind of politically and culturally, so that you can bring in examples of things in the real world into. And certainly, the health equity problems of COVID have been an interesting thing to consider. So in terms of psychological safety, there's kind of 3 levels of it. There's an individual level. Do you feel safe saying things and a lot of people have psychological safety on Twitter that they probably shouldn't have. But there's also the group aspect, and that's, you know, how do you develop psychological safety just within the people that are there? And then there's on an organizational level. So if, you know, as one of the things that we're trying to build at Stanford is this organizational psychological safety where you, because you have many events like this, you can start to feel comfortable addressing it in other circumstances that aren't that group of people that you are just with. And then I think there's, you know, many papers, et cetera, on how do you build psychological safety. And what I found to be most successful for me is first you have to validate what people are saying and then paraphrase it so that it kind of is coming from another group. But for me, normalize what they're saying and say it's okay. You know, lots of people go through this. And then for me, it's really been demonstrating my own vulnerability and my own ability to understand that I have, you know, implicit and explicit, I'm sure, bias, and how do I go about addressing that both at work and then also in other circumstances. And so that has seemed to get people okay, you know, more willing to talk and I do the same thing for, you know, medical mistakes or diagnostic errors or whatever. As soon as you're willing to share your own experiences, I think people are more willing to talk. And then certainly getting lots of feedback throughout is very valuable. Okay. All right.
So I know I usually take a break here for folks. What was your impression of that exercise? Open the feedback, open your first thoughts or your gut impulses, going through the case, hearing what the group thought, and even kind of thinking of some next steps. What was your impression?
Need more of it?
Need more of it, absolutely.
I thought the conversation was, I think, well focused on how you're coaching learners. But I think at a you know, conference we've done, which is emergency medicine, just sitting in the same room, we have an opportunity for kind of engendering or kind of putting together some collective action, collective policy goal. Because there's a bunch of people here, right? So this is really useful to take to your individual shop to teach the residents. But then you also have the duality of like, well, what can we do individually as opposed to just imparting to medical students and residents. So that might be just a little bit of like a missed opportunity.
We're not done yet. Say we're not done yet.
Yeah, that's the part two. Go ahead.
I'm wondering too at the end, is there any role for kind of like putting up like a key point slide for like the top things within, like, you know, you have your foundations talk and then there's a lot of concepts that come up and then those concepts can then be brought back to the very end as a part of like, here's what we covered during this session, which included, you know, health disparities with respect to access to care or differences in, you know, just so that at the end of the session there's like kind of big key points that were brought up.
So this is kind of the bridge version based upon the time for the workshop, but usually in the single isolated session, in the final portion, there's like a summation slide, a recap, make sure they understand the language that we use, similar to the one that you saw earlier. And then when I've done it actually in person, we collect what the brainstorm outputs are and then go over those as well. Like, so these are the things that you all said you'd like to see happen. And how do we assign roles or ownership to that? So it turns into an activity. But this is, again, a bridge version for this workshop. But I agree with you, having that there is super helpful.
We also generally have gone through like 2 or 3 cases since people don't necessarily have so much to say about one specific case. You kind of keep on offering up cases until one really seems to stick. So some might be a 10-minute conversation and then you're just into the next one, which is like a 40-minute, you know. So we've been doing these in about 2 hours, but we're obviously being a lot more explicit about what we're doing as we go through this. So the first, you know, parts of it don't take nearly as long, and we spend a lot more time specifically on the cases.
Maybe we'll talk about it in part two, but like compliance participants, right? Like you can force this stuff down people's throats, but people come from different backgrounds. And, you know, some people from certain parts of the country will be this and be like, oh, this again, like I don't want to hear about this. And they're so ingrained in their thought process, they're not willing to unlearn what this
I mean, I can address a little bit of that now. I think that part of it comes in the creativity of the cases that you develop. You can go as in-depth as you'd like. When I've looked at cases, I try to find one that has multiple layers, not just one clear thing, like, okay, this case is about, somebody writing something in the chart. That's the one teaching point. No, I want something that has like 4 or 5 teaching points out of this one case, so we can talk about how they all interact. The other thing is, it starts to become very facilitator dependent. So you have to really structure you have to build facilitators who are able to have those levels of conversation as well. Because otherwise what ends up happening is there's going to be learners in the space at different levels, and they're going to seek different information. It has to be somebody that they can access to either be a touch point for the information or can give them direct resources so they can learn more. The biggest concern that I have usually is that it ends up being some type of weird minority tax where people who are most adept in this information end up doing the rounds and end up leading it and going through all these conversations in general. But the way that this round is designed is that anybody, even to the point where I intentionally did not lead the rounds because I wanted you to see what it was like when somebody didn't lead. That was a person of color. Like that, there has to be a lot more intentionality in terms of the facilitators, and that will add to the level of depth that you're looking for.
I think some of the setting of the values too is very important for that, because as soon as you have everybody contributing to their values and then being silent on how those values are not helping people, it's, I'm from California, we're from the Bay Area. we're still learning this, but if I would be curious if people are like pre-contemplative on social drivers of health, even just existing in this session is going to probably be eye-opening for a lot of people, even if they're not necessarily contributing. I think getting a lecture on how it's important is quite different from being part of a discussion. But I certainly, that's part of being a good facilitator too, is if you're seeing eye rolls, if you're seeing phones come out, you have to, figure out ways of drawing them back in. All right, I think we're going to do like a 10-minute break. Does that sound good? We've been around 2 hours, so we'll come back at 3:10, and then we have many cases, but part of what we're excited to do here is kind of have you guys go through some of your own cases so we can learn from a national group of people on how this is affecting you at your own institution. So, all right, we'll see you in 10 minutes.